when a normal person is exposed to any virus, our immune systems generate a response to it, and we engage our adaptive immune system to start creating these antibodies. And these antibodies will have affinities for parts of the bad guy, and the coronavirus has these spikes protruding from it in many directions. These spikes have surface features on them that are called the receptor binding domain. That's part of how this virus is able to latch onto host cells to infect them. And so generally the antibodies that have good affinity for the coronavirus or the SARS-CoV-2 virus have affinity for the receptor binding domain specifically. And so when these antibodies stick onto the receptor binding domain, they are basically preventing the virus from using it in order to infect another host cell, which is helping us reduce the rates of new infections. And so ideally what we would expect to see is, as we introduce some antibodies into a patient who is just exposed to the coronavirus, they just got infected, what these antibodies will hopefully do is they'll stick onto the receptor binding domain. The coronavirus progeny are going to have a really hard time finding any host cells to infect when they've got these antibodies literally stopping them from infecting any new host cells. And so the gist of it is that Eli Lilly, along with some other research teams at Vanderbilt, have been taking the antibodies from patients who have been already infected by the SARS-CoV-2 virus. They overcame it, and then we are looking at these specific individual plasma cells that are making these unique types of antibodies to see which antibodies have the highest affinity for particular features on this SARS-CoV-2 virus, and then we're scaling up production to have enough to go into clinical trials. And so the drug that Eli Lilly was testing here was called LY-CoV555. And so if this was like a natural antibody, you can think of the engineered antibody that Eli Lilly was testing to be this white thing right here. And so basically they've been administering these engineered antibodies to a couple hundred patients in a placebo-controlled randomized trial. And so what this means is that if you were enrolled in this trial, 150 of the approximately 500 or 600 cohort would be enrolled into a placebo, meaning that they would be given a medication that didn't do anything. And then there were 3 active study arms that involved different doses of the antibody. And so this special engineered antibody that should be able to stick onto the receptor binding domain and block or neutralize the coronavirus, we gave these in 3 different doses, a low, medium, and high dose, to these groups of patients. And at the end of the trial, what we saw was that patients who were given the active version of the drug, the non-placebo, were 72% less likely to have to go to a hospital because of severity of symptoms. So that is really promising findings. And to throw some numbers behind this, 9 of the 150 patients who were in that placebo group had to get hospitalized after they had a infection by the coronavirus of 3 days. So they just got infected by it, so it's a fairly new infection. And then of the 302 patients that were receiving the actual drug, 5 of them needed to get hospitalized. So basically this drug, the neutralizing monoclonal antibody, is doing what we were hoping it would do, in that it's preventing hospitalizations. Now, despite having this very nice decline in rates of hospitalizations, the interesting thing here comes in that the main goal of this trial was to see whether or not the viral load inside of patients would decrease at day 11 after their infections. And the only group in this clinical trial that had the drop in viral load was the group of patients receiving the medium dosage of the engineered antibody. And so this is leading to some skepticism of the validity of the data, because ideally what our intuition is suggesting is that as we increase the dosage of these engineered antibodies, if you've got more engineered antibodies, then there's going to be more blocking events occurring inside of these patients, and therefore it would be even harder for the virus to create more progeny at higher doses of the antibody. Therefore, we would expect even lower viral loads with higher doses, but strangely, we're only seeing the decrease in viral load occurring with the medium dosage of antibodies. So that was a very interesting finding that is causing some people to take a step back and take a second look at this data. So definitely some new questions there, but nonetheless, 72% is 72% in this group, and there are additional trials currently underway to determine whether or not this is a statistically significant finding. Eli Lilly also has another drug, LY-CoV016, in the works, and it too is another engineered antibody, but this one has affinity for a different region on the receptor binding domain that might make it more effective. And the other nice thing about what we've learned thus far is that these monoclonal antibodies that we've been using have had no serious side effects, so we're not seeing anything bad happen in the patients who have been administered these treatments, which is a very good finding. And you can learn more about these trials that are underway by reading the description below. Hope this video helps. Thank you all for watching. Please stay safe, wash your hands, and I'll talk to you all next time.